I'm going to introduce our first speakers, and the topic will be improving clinical documentation. It's Dr. Kathleen Bowen and Jennifer Bratz. They're going to both bring a little bit of a separate perspective, but a collateral perspective together on the topic here about clinical documentation. Dr. Bowen is the Medical Director of Operations for Edison Physician Advisors in Birmingham. She is board certified in emergency medicine, holds an MBA from Auburn University, and is also a certified professional coder. She worked for Blue Cross Blue Shield for a number of years, and prior to accepting her current position, served as medical director. I'm not sure I'll get this right. Covatina? Something. Okay. It's something that we don't say in South Alabama when I grew up, so never mind. All right. Next is Jennifer Bratz. Jennifer is the Associate Vice President for Quality Management at Baptist Medical Center South in Montgomery. She has more than 20 years' experience managing quality, informatics, clinical documentation improvement, and health information management departments. She has served on a number of state and national healthcare boards and has degrees in health information technology, healthcare administration, and health information administration. I believe Dr. Bowen is going to go first, and we will welcome her to the podium, and after they speak, we'll try to have time for questions. So again, please save your questions, and we'll be ready to go at the end of that. Dr. Bowen. Thank you.
Okay, so patient care, payment, and the penalty box. I thought it was just amazing that I had written about going to the penalty box before knowing that we were going to be in Pelham, where we, sorry, I'm a wanderer, I apologize. Yeah, maybe we should do that. Let me do that.
Yeah, go ahead.
All right. Okay. Oh, awesome. So I wrote this talk prior to knowing that we were going to be in Pelham, where the Birmingham Bulls are, and so I just thought, this is great. I'm talking about patient care, payment, and the penalty box, and we're in Pelham. So, you know, hockey is a very interesting sport to watch. When we watch hockey, you know, it's not like watching football. When we watch football, we're sitting on the couch, we can be the quarterback, we can be the ref, we can shout, oh, come on, that was pass interference. And if you're going for the other team, no, it wasn't. That was offensive pass interference. But in hockey, things are moving so fast. It's really exciting to watch. These pictures are actually from a game that I caught in Pittsburgh. The puck is flying, the players are skating up and down the ice, and then all of a sudden the gloves are coming off. There are two guys on the ice just punching each other, and the ref, you know, if you're watching on TV, the camera zooms in on the ref, and the ref is standing there, watching it all. And you're like, isn't that like a foul or a penalty, or what is that? And so then all of a sudden, you blink your eyes, or you go to, you know, grab a nacho, whatever, and there's a player skating off the ice, head hung so low, going to the penalty box. And you're like, what? How did that guy go to the penalty box? What did I miss, right? Was there offensive pass interference or what? And so I have to tell you that this is exactly the environment for us, the healthcare regulatory environment in which we are practicing and delivering care. We turn our heads for 1 second, we miss the infraction, whatever it may have been, and we wind up in the penalty box. And the penalty box is quite serious. You know, in football, you get a little slap on your wrist, oh, you lose five yards, or oh yeah, back to the spot of the foul. In hockey, that player goes into the penalty box, and the opposing team gets a power play. And this is what CMS wants from us. They want the power play, because for them, we're on the defense, they're on the offense, and they're going to score. And for scoring, that means that they're going to find a way through these penalties that we've committed to go ahead and create a revenue stream that is quite substantial for them. I did bring, it's not in the PowerPoint presentation, but yesterday in my email, I received notification that a hospital in Iowa, and I have to read it, I didn't memorize it, sorry, $1.88 million settlement to the government for inpatient versus outpatient. So the government was able to negotiate $1.88 million with this hospital for alleged abuse under the False Claims Act. That is a huge settlement, and that is us sitting in the penalty box. So let's go through and see what we can do about it, right? How do we not go in the penalty box? So let's, let me get my clicker, sorry. All right. We all understand, or we think we understand, that the basic premise of what we do is that we provide medically necessary care and that we want to get paid for that. And it doesn't matter what part of the healthcare delivery system we're involved with, whether we're in nursing, we're doctors, we're administrators. We want to deliver good healthcare, and for that we would like to make a nice living, support our families. This is what we think we're doing, and it seems so self-explanatory. But really what we're doing, and every single one of these underlined words, is an area of risk. We're providing, documenting, and being paid for medically necessary care as the fundamental cornerstone of our healthcare delivery system. The documenting is the key, because without documentation, everything we do for patients doesn't exist. And that's the single premise. And each one of these represents a challenge for us. Go with me here. This is outside the box. You got to sort of leap with me here. So what is medically necessary care? How do we get paid? How do we document that's within the regulations? And then what is providing care? So think about what we do. Every day a patient presents to our facility, reasonably a human being, the most complicated organism on the planet. We're expected then to have the provider take in the information that the patient has translated into words, put that together with signs and symptoms of disease, make a care plan based on that, as well as a differential diagnosis and an algorithm for treatment. In the electronic medical record, which by the way does not allow for the flowery notes of old that really went into how the patient looked, how they said they felt, the gestalt of that patient. So now we have the EMR. Then we ask another one of our team members to take that abbreviated information. So we've gone from a patient, the most complex organism on the planet, down to EMR documentation, and we ask another team to change that into a series of alphanumeric or numeric codes. And it is no wonder, and there's no reason to even think about it, that what we're left with is this. Is there a question in anyone's mind why there are errors committed that we are unaware of and why we're sent to the penalty box? So, yeah, this is a patient, V91.07D. That is the representation of what happened to a patient. Think about that. So, who's looking at this? Who are our referees? In our arena, we do not have the one ref skating around. We don't have the ref and the sideline refs. We've got all of these entities looking at us. Recovery auditors, quality improvement organizations, zone program integrity contractors, the OIG, the DOJ, more initials than you can imagine, and the list keeps going. The bottom one is very important. There is now a bar for whistleblowers in the lawyer community. They actively seek out whistleblowers at your institutions to help them bring a case because the money involved is tremendous. So, I know we said not to be scared, but if it feels like the government is hanging over you like this picture, you are correct. If you fall outside the norm, they are going to find a reason to come up with one of these settlements like they did with the Iowa hospital. So here are our penalty box risk areas. Medical necessity, inpatient versus outpatient, care notes, the EMR encoding, that's really about cutting and pasting and upcoding, and then the physician query process. Now the bottom two, where I work at Med Management, the other ones, we have been doing those cases for years and years and years and really helping hospitals and providers navigate that regulatory environment. The last two are new, so two new things have been added to our list of what is being investigated. And as you can see, these 4 things relate back to the 4 underlined words. So what is medical necessity? Is that the care that was delivered by that provider? Did that provider make the right choice when listening? Was the expectation set when that provider was listening to that patient that they would require inpatient services at your hospital? And then the EMR, what problems does that EMR create? And then the physician query practice. So now we're obligated to code to the maximum specificity. That has been our directive. But at the same time, we are not allowed to lead physicians to a diagnosis because that goes against the standards. So let's start with medically necessary care. This is truly the biggest one. So medically necessary care is defined by the government. It is not a medical term. It is, as it's quoted here, items and services that are reasonable and necessary for the diagnosis or treatment of illness and injury. It goes on to say that it needs to be provided economically and only when and to the extent that it's medically necessary. So you see how it kind of goes in a circle. And then the Social Security Act goes on to tell us what is not medically necessary. No Medicare payments shall be made for items or services which are not reasonable and necessary for the diagnosis or treatment of illness or injury. And I do have a caveat. Most of what we do is with government payers. But if you meet the standards for the government payer in terms of medical necessity and adequate documentation, you'll be doing great with your commercial payers. It will make your conversations with them, with their medical directors, much easier. And your denials rate, even from your commercial player, will go down significantly. So part of that is the nebulousness around that statement, reasonable and necessary. So how are we to know, as providers of healthcare, what is reasonable and necessary? These are all the resources that you need to be familiar with. Agency rulings, the MACs, LCDs, CMS guidance, and publications that come out periodically, what's on the work list, and federal regulations. So why is this important? Well, we all know that medical necessity is the foundation, and medical necessity has to be properly documented for the medical care to actually be perceived as actually having occurred. But these are the reasons it's important for your institution. Financial well-being. If you can support your medical necessity, your payments will be adequate to support and help your hospitals flourish. The fixes, the back-end fixes to defend against the lack of medical necessity are very expensive. And they will show that if you have a weak-end process where you're not documenting and supporting medical necessity, you will have to fix it on the back end, and it is tedious. So the patterns of denials, these are also watched. So if you have a pattern of medical necessity denials, you will be subjected to greater scrutiny and further audits. And then from an internal perspective, if you have compliance challenges, you will find this out when you start taking a look at your medical necessity denials. And then the big one, $1.88 million in settlement, false claims liability. You do not want to be accused of fraud because of not meeting medical necessity requirements. False claims liability gives rise to both civil, criminal liability, and it is both corporate and personal. So when you're in the medical necessity and the penalty box. So there is no way that any of us in this room believe that there was $1.88 million worth of fraudulent charges created in Iowa, right? No one believes that. And for the most part, what we see is that there are, I'm not saying there's not fraud, don't get me wrong, but for the most part, it's poor documentation for really good medical care. And so the way that the False Claims Act is being used now, we used to hear about, oh, do you remember that company that sold all those pieces of equipment that weren't really in existence and all that? That was then. Now, the False Claims Act is being used as a tool to seek criminal and civil liability for failure to comply with regulatory guidance and interpretations, such as billing for services that are not medically necessary. In this case, for Iowa, the U.S. State's Attorney for Southern District of Iowa goes on to say that our office will aggressively use the False Claims Act to ensure all healthcare providers play by the same rules and taxpayers do not pay the bill for unnecessary services. Well, the definition of unnecessary services now falls within documentation guidelines. So here are the building blocks. This is what we share with our clients. How do we address this in the documentation, and how do we address it with our physician advisors and the hospital-based physicians who are really the champions of this with their case management and utilization review committees? So it's very important that if you could take this back to your institution, a little pearl on the documentation. If you can encourage your providers to concentrate on the patient, and actually everything we do, the patient always comes first. So when it comes to documentation and speaking with your physicians, why not always keep the patient at the forefront? Have the physician or care provider, expand on the severity of the illness, the risk associated with that illness particular to that patient, what services are required to address the threat or reduce the risk, how long does that provider really think that patient is going to require services in the hospital, and knowing when that care began, where are the services going to take place, is the whole care plan going to happen in the hospital setting, or is there a transition that's expected, and then finally, why? And why really goes back to the who. Why is that patient expected to require those services in the hospital for the anticipated amount of time that's been documented? So that was the first risk area. Our second risk area is pertaining to the $1.88 million, inpatient versus outpatient. Seems like it should be a medical question, but it is not. It is a legal question, and it is a legal definition. A federal judge decides when inpatient admission is necessary under the Social Security Act. This is why it's very important that our teams, utilization management, case management, physician advisors, that we become the translators for our clinical staff. Doctors do not understand this part of delivering care, and I'm not quite sure it's reasonable for them to actually understand this part of delivering care. They have spent their entire adult lives learning and to practice medicine. It is an ongoing pursuit with experiences and dedication. And I say doctors, but I mean all care providers, so forgive me for that. And so I do think the role for individuals like ourselves is to be the translators for the clinical staff so that we bridge that gap between what is a government regulation, what does that mean to us as what it means to a physician providing that care. So here are the federal regulations. I am going to read these all to you, just kidding. I included them so that in your spare time you can go ahead and go over these. They go on and on and on and on. And every time I look at them, I get like, oh, goo-hoo. I'm like, oh no. So I have condensed them into the common terminology that we use, the 2-midnight rule. So the inpatient admission is appropriate when the provider expects the patient to require a stay that crosses 2 midnights. Now that means that when they present to the emergency department at 11:59, guess what happens at midnight? It's the first midnight, right? So you've already met half the criteria to be an inpatient admission. Of course, the caveats are there is the expectation, and how do we set the expectation? By documentation, that the patient will stay in the hospital at least 2 midnights, and if they're newly intubated in the hospital, that's a pass. And then the third way to be an inpatient is to undergo a procedure that's on the CMS inpatient only list. So the second part of this law is that there are conditions of actually getting paid. So once you meet all the medical criteria, that there are conditions of being paid, and they're set forth here. You have to, the physician order must be present in the chart. It has to be supported by the admission and by progress notes to be paid under Part A. And then the second part of this, Part B, the licensed practitioner must have admitting privileges at that hospital and be knowledgeable about that patient, meaning, not just anyone can sign off on this. So here it is in I think a much easier format. You start at the bottom with the 2 midnight rule. is the expectation that they're going to cross 2 midnights, or are they intubated, or do they have an inpatient-only procedure? And you build up and say, okay, then we've met those criteria. Do we also have the substance, the medical necessity of an inpatient admission order? And then you write the order. The technical part is in yellow. So a privileged practitioner needs to sign timely, which means it has to be signed before they're discharged from the hospital. And is it technically correct, meaning that it meets both parts A and B under conditions of payment. So here's our status challenge. Now clearly, the guy on your left is an inpatient. And the fellow on the right, well, he is clearly an outpatient. Well, yeah, they're twins, and they're on the same floor in the hospital, and they presented with the exact same complaint. They have the same physician. They're getting the same treatment. No. The difference in these is the documentation that supports the inpatient stay versus the outpatient. And why do we care about this? Again, patient first. When you're speaking with your providers, it's not, we won't get paid if you don't blah, blah, and this doesn't mean. No, the approach is, you know what, I need to share with you that it's very important that we get the status of this patient correct. The order, you don't even have to say status. You can say the order of whether they're inpatient and outpatient, because it affects their co-pays and it could affect their deductible. And if you're thinking that they may need post-acute care services, it will affect their eligibility to receive those services. The second part is financial viability for your institution. And you know, I don't know what's happened over the years. Hospitals and doctors used to be in sync, and financial viability was good for everyone. And it seems like maybe there's you know, a little bit of a disconnect that what's good for the hospital doesn't really affect me as a physician, as a provider, and that of course is not true. So the message that we've been trying to share with hospitals to share with their providers is that if you get the inpatient order right, and I'm not saying commit fraud, get it right, you are reimbursed very handsomely for that. And financial viability of your institution only contributes to better patient care. The resources are not diverted away from patient care to do, you know, defense and appeals and whatever else. If there is financial health of your institution, that then translates to greater resources and hopefully a better care experience for the patient. And I think that is the way to speak to your providers, to convince them that they have a stake in this game. They want what is best for that patient, and if they're able to offer them the newest and greatest, you know, laser therapy, or have more care managers who can get them to where they need to be, or, you know, increase nursing staff on the night shift, because that's when things, of course, go wrong, when there's no one in the hospital to take care of them. These are ways to convince your providers that they have a stake in the game and it is important to participate. Oops, sorry. Let me go back. Well, the other one goes back again to why it's important. It's because that all this documentation about inpatient and outpatient is evidenced by this case that I keep referring to because I was just shocked that it came in my email box yesterday. I was like, oh my gosh. It leads to liability. And I think it's very important to be cognizant of the fact that if you don't get it right, you're setting yourself up for consequences. So here are the pearls to take back to your institutions. You have to show a valid institution, and we can all help the clinical care team you know, understand that including current medical needs, risk of adverse events, history of, and comorbidities, very important. You know, painting a picture around why the patient's that sick and what contributing factors are making them that sick is very important and goes a long way to support the inpatient admission. And then, of course, the severity. You'll see the little note there that it has to be documented in the chart to be granted consideration. Back in the day, you know, a doctor used to be able to say, they're so sick, I'm making them inpatient because I say so. Well, CMS has actually come out with a statement that said that the physician's statement actually carries zero weight. It's only the documentation within the medical record that supports inpatient admission. So here is how not to validate the expectation. If there's anything that I could impress upon you that I see with our clients across the country, is this first one. MD, unsupported predictions or contradictory statements. The best example I have of this, and this has to be removed from the documentation. So a patient comes into the emergency department overnight, sick as snot. You're like, oh my gosh, I can't believe they even made it through the night. The emergency physician does all these interventions, maybe puts them on BiPAP, Lasix, IV antibiotics, maybe resuscitation, everything that's needed to get that patient back to the living. Then the hospitalist, the nocturnist, comes down, looks at the patient, is very involved in the care, writes a beautiful note. Oh, so sick, has made it past the critical, will definitely have to stay in the hospital more than 2 days to stabilize. 10 hours later, the daytime rounding hospitalist comes by, writes a note, patient looks great, discharge. This is conflicting information and will not help you with the inpatient admission. That inpatient order was written at the time that the expectation the patient was going to require 2 midnights worth of medically necessary care, and we need to stick with that because that was their presentation and that was when the order was written. The other custodial care and convenience, the documentation, if we could limit that documentation, people, I'm not saying to commit fraud by any stretch of the imagination, but there are ongoing medical needs at the same time that discharge planning is taking place. Those two things are not mutually exclusive. So here are the building blocks. I'm sorry. Again, it's a who, when, what. Who, it has to be the admitting practitioner who has privileges, or it can be a co-signed order, and it must be signed prior to discharge, and it must clearly state admit to inpatient, otherwise indicate that inpatient status. Cannot be delegated, and if this is not valid, you will not be paid. There is no wiggle room whatsoever. Here is how the practitioner can support if you have a documentation effort. And the question did come up in the doctor session this morning. You know, how do you communicate with your doctors? Well, a number of clients we work with, they just do it during their staff meetings. They'll bring in a clinical documentation expert and meet with the clinical staff and go over, just have a small, not onerous, sometimes they'll do a coding session and why it's important, or clinical documentation. So document effectively the unique patient specifics, document support for the inpatient status at every note, and then if there's any ambiguity in the chart, clarify that immediately. The role for the utilization management and case management teams is new, and it's wide open. Those teams can be the translators, as previously mentioned, for the care delivery team, promote the verbal communication between the care team, come up with efficient ways for that communication to happen, and then encourage the utilization team to help the care team complete their documentation before the patient is discharged. Now, the important caveat is what we do is we read everything as auditors. If you can take your staff and teach them to look at every single chart as an auditor and make sure that all the elements are present, it would really help your institution with the inpatient order. The next pearl is to have a denials management strategy. No matter how well you document, no matter how excellent your processes are, you are going to have some denials. Be ready for that. Do concurrent patient reviews. Have on-site timely reviews that are then referred to a physician advisor if there's any question, and then encourage, again, the peer-to-peer conversations. Pre-bill audits. Check to make sure that that bill you're going to drop in the mail, that it is actually reflecting what was done and that the appropriate status is on there before you get in trouble. Then, if you do receive the denials, have a process in place where you can identify the denial rationale, go back through the chart, see if the denial was even valid. 50% of the time, the denial is based on something that is not valid and should have been paid. This is money that is lost to your institution if this is not undertaken. Once you do identify the 50% of the cases where there is no valid denial rationale, be prepared with your appeals and your defense. So, care notes, EMR, and coding. Really, from this section going forward, Jennifer is more the expert. I've included them because it's what our clients are coming to us and saying, hey, we need help. So CMS has come out and said, this is actually a 2014 reference, $250 billion, and that the EMR is actually contributing. Of course, We were mandated to adopt electronic health records, and now they're finding that they have created a series of opportunities for error. So the biggest ones, of course, are the cloning, the cut and paste, the bring forward, importation of information that has not been reviewed for accuracy. And the medical record, it is supposed to accurately reflect the facts and occurrences that occurred during that visit, not the hospitalization from 6 years ago, not the note from a different patient that's been inadvertently imported. And there was also, just a side note, there have been fraud allegations for medically unnecessary elements included in the medical record because it was not pertinent to that visit, that note on that day. So pretty significant. Some solutions. I did learn during the session this morning that the newer EHRs are including caveats that if you cut and paste, bring it forward, clone, whatever, that it will actually automatically put that in there. But things what we have seen physicians across the country do is they will attribute a brought forward element to the original author. They will actually note when they re-review it, and so every third day or so they'll say re-reviewed information from previous, which is a very effective strategy. And then the last one that I saw most recently, a physician didn't really wade through all that stuff and didn't try to delete all of it, but just wrote his own little note dated, I on this day have these impressions of the previous information, and wrote like a 5-line summary. It was awesome. So this is the last documentation solution note that I have. In the past, when we discharge patients, we could write a discharge summary. Oh, patient came in, they had a heart attack, went to cath lab, they did great, they're going home. So this is not how it is any longer. If there's one thing that needs to be supported in the medical record, it is the discharge summary. There is clear guidance around what should be included in the discharge summary, and it actually turns out to be good advice. So include the reason for the hospitalization, include the chief complaint and or the HBI, and if you're only doing the HBI, the chief complaint is mandated to be included in the HBI. Any significant findings, events during the hospitalization, all the risks, always talk about risk, addressed during the hospitalization, and then concluding diagnosis, procedures, and treatments. The reason this is so important is it addresses the medical necessity, it addresses the physician query process, and subsequently what is coded for that hospital encounter. So here's the physician query process. This is actually from the game in Pittsburgh again. It was awesome. The crowd was into it. This is originally what CMS came out and told us we were allowed to do. We do not believe that there is anything inappropriate, unethical, or otherwise wrong with hospitals taking full advantage of coding opportunities to maximize Medicare payment that is supported by documentation in the medical record. Sounds awesome, right? Yes, we want you guys to code everything that happened to your patients. We want to pay you for that care. Well, the Quality Improvement Organization Manual has come out in 2014 and is directing the reviewers to specifically look for the appropriateness of the DRG. And then at the bottom, this is all lengthy, it's for you guys to read at home, but to look to see if the query is leading. So you're like, okay, what is a leading query? And I think Jennifer is going to pop in here and help, because what we have taken on as a task is to defend the medicine that had been delivered and not really address the what is a leading query. So here's the guidance, Jennifer. Anytime you want to pop in here, that'd be awesome. You want to?
Yeah.
Okay.
So those are the things that we have to worry about. You really don't want to say or even have what we may know with that clinical picture is the... All right. It's okay. She's fine. I don't walk as much as she does. I'll behave, and I'm shorter. So the leading query, you don't really want to write, whether you're doing it verbal or even if you have it on paper, your queries. You just want to make sure that they do not actually say with those diagnoses that you know what that is. You want to have the options. You always want to have other, so almost like a blank, so they can use their clinical judgment. But the big thing is even though we may know, and most of clinical documentation specialists are clinicians, they're nurses and others, we may know what the answer is, and we may know to the specificity, but if you put it down there, they're really going to say, you're almost like at the top, say, pick me, pick me. That's where we really get in trouble. So we have to be very careful and give the options. And I also say, if we're doing the queries, we need to make sure that maybe the focus is not so much on the coding language, which a lot of physicians look at that and say, this doesn't make sense, you know, and it doesn't, because it's not clinical language, it's financial language, right? Just put those clinical indicators. What's going on? What's the temp? What do the CT scans say? What do the labs say? So you're painting the picture. And those are the things that'll keep you out of the penalty box.
Awesome. Thank you so much. And so this question of leading, don't go away. You gotta keep helping me.
Okay.
This question of leading is important because that is actually the phrase that is bringing the hospitals under investigation. Mm-hmm. And I've further included some guidance. That guidance was very vague. This is awesome. So a query should be considered when the health record documentation is conflicting, imprecise, incomplete, illegible, ambiguous, or inconsistent. Makes perfect sense. Of course, we're going to, query our providers if any of that exists. But while you're questioning them about that, you're not allowed to lead them to a diagnosis, and you're not allowed to question their clinical judgment, even though you want to say, doesn't that all mean that they have pneumonia? Can you just put that in the chart, please? And so the next part, that's again very interesting, describes or is associated with clinical indicators without a definitive relationship to an underlying diagnosis. Or the opposite, you have a diagnosis that doesn't have any of the clinical indicators when they're all right there in the chart. But if you bring those all together with one word out of place, guess what you've done? You've led the physician. And the charge associated with leading the physician is that you are upcoding, that you are increasing the value of that hospital stay for financial gain. Not that you're trying to accurately reflect what happened in the hospital, how sick the patient was, and code to the maximum specificity. No, you are doing that specifically because you want to increase reimbursement. That's the charge. You have something to say?
No, that's just another area where you just have to make sure you leave that query open-ended. You've got to allow that time and place to be able to make that clinical judgment without you feeding it to them. Which leads us to this.
So this is my representation of the physician query process. You are walking the query tightrope. One step this way, you fall over. One step the other way, you fall over. And it really, everything that I read on the subject, we've had several projects come in on this specific issue, is that the process must be validated with your internal resources, including the lawyer team at the hospital, before putting those queries into action. Because if you have a compliant query, the question of leading does not come up. And that is, I'm going to hand it over to Jennifer because this is her area of expertise. Thank you.
Thank you. All right. So just going back to this slide, I was laughing when Kathleen and I were going over, which started out as maybe 100 slides. We were being kind. You could tell we're very passionate about these topics, but we don't want to leave our physicians with this kind of impression. So this part, the second part of this is really, how can we make our physicians, or even the entire team, not feel like we're walking on a tightrope, right? And that is that team approach to that. Now, I do want to start with a couple disclaimers. One, I am not a coder, but I know enough to get myself out of trouble usually, and then they tolerate me to speak for them occasionally. And two, I'm more into probably football than I am hockey, so Kathleen had to give me a little pointers on that whole thing. And I am learning since moving to Alabama, you don't really talk about which team, because that can get a little heated, so. All right, so on this next one, the importance of accurate documentation and coding, we really talked about that. We do have a lot of compliance and risk issues. I worked in compliance for 6 years before I started doing other things and got back to quality. It gets a little depressing, right? There's a lot of legal stuff and you've got to know, so thank God we have people that kind of help guide us through that are part of that team. But we also need to look about the reimbursement side. So not only can you lose money by getting sued and doing things that are inappropriate, like leading queries, but also your public perception of your hospital, and then just making sure you get correctly reimbursed. Now, used to you just focus on DRGs, right? Because I know a lot of physicians that some of the stuff that they take away is DRGs, right? Which DRG? Well, it's really shifted to the entire picture of the patient. We need to not just focus on the DRG. And to Kathleen's point too, Dr. Bowen's point, picking that DRG, that's not the be-all and end-all. Even though coders have that opportunity, if the care is equally provided to two different DRGs, which occasionally, especially in our sicker populations, can be the fact. So those resources can go to either. And then they can choose the one that gets the greatest reimbursement. But we need to start thinking beyond that and at least educating the physicians and the healthcare team is value-based purchasing, right? So you may have a DRG or might go to a sepsis, but AMI, heart failure, pneumonia, we know those are big no-nos areas for mortality, readmission, and those kind of things. So when you're looking at that, let's just make sure we're looking at the entire picture and say what's best, what's the most appropriate code. We always want to do that. But if you have a choice, you need to look at that. And again, we hate to say it's like gaming the system, but we get looked at publicly for those kind of things. So we need to make sure we're thinking ahead. So severity of illness, risk of mortality, those are huge things. If you hear the SOI, ROM, you can also get your coders to help you if you're trying to learn this stuff. They actually have like encoders that can kind of play with that to let you know whenever, and that's a grading system. So you want to look at those, especially if you've got patients with high mortality. Or that have expired. You want to make sure that they're not showing a 1 in 1, which means we should have never, they should have never expired. We did something wrong, is that perception. And then you hear about HACs and HAIs, hospital-acquired conditions and infections, PSIs. We love acronyms in healthcare, patient safety indicators. I made sure I spelled it out so we weren't doing that. So if you're taking these home, you can look at those. And then appropriate capture of what's going on. So you really want to, again, paint the picture. If you do that, you're protecting yourselves on both sides, and you're also giving that accurate portrayal of how sick your patients are. And physicians, that is so important for you, and we're going to talk a little bit more about that. Again, reimbursement. So would you rather not do a good job documenting and coding and then not be able to hire the care coordinators, case management, or get your extra nurses, or get PCTs to help you be successful and take better care of the patient, or get credit for the care that you provide? Those are the things we really need to focus on. And then the allocation of resources. And now a new thing too, and I haven't heard it so much here, but working in an accountable care organization in population health a lot, HCCs, and I don't know how many of you have heard of those hierarchical condition categories, but physicians, you probably heard a little bit more. It does relate to your macro MIPS and your APMs as well. That's that overall picture, that risk adjustment, and it's not just that patient care. That is the entire continuum. So that stuff goes with you to your rehab. That stuff is every patient visit. And those are the things we really need to focus on, and we're going to talk a little bit more about the continuum and how to bring that in. So the list just goes on and on. All right, so these are just some of the areas that are impacted by accurate and complete documentation. Some of the things I'd like to talk about that is really that's helped you get your physicians engaged a little bit. There's what drives each of us is sometimes unique. Some doctors are driven by their public perception. Some of them just totally care about the patient. Some of them really want to make sure they're paid well. It doesn't matter, but you need to know where that documentation, the power of the words that you say, and how we translate those affect us. And you can see that that is just some of those bundle payments, CJR. That's one of the things that we work on a lot at Baptist. We look at bundle payments for AMI. We're looking at those in the future, so we really need to keep a close eye on those things. But present on admission is real painful, and joint commission, again, physician profiling, risk management. And we love that value-based purchasing, right? Okay. Other areas that we like to look at, quality is really big on that, but I don't know if you guys know as many hits or information where you can find out where your hospital is looked at and where are you individually. And one thing too I like to share with my physicians too is you're linked. So if you have privileges at the hospital, at any hospital, you're basically, your reputation's linked to that hospital and vice versa. So we really want to make sure that we're working together to understand that. It's not just your U.S. News reports that comes out every year, but you're really looking at things like, believe it or not, Yelp. I've gone in and showed physicians too, where you can have very bad reviews on that, just like restaurants will. And then the danger for some of the physicians too that get really irate on that is you've got to be careful. You can't really, type a reply and then you worry about HIPAA and some other things, right? Of saying, well, if you had gone to your appointment, you wouldn't be sick, those kind of things. So we kind of do little coachings of, you can be cautious, just, let it go. We're going to focus and make you supportive on the ones that are more important. Leapfrog, CMS, health grades is a big one. None of us really want to be associated to hospitals that are 1 stars. We want those 5 stars across the continuum of, that's like your report card. And we get reflected to that. I always find it's a challenge to go to a facility that may have those 1 stars. And I think some of my biggest, feel-good moments were helping an organization go from like 17 1 stars to the 3 and 5 stars within 3 years, and that takes time. So that's the other thing too I want to portray to y'all, and especially for those of you that have quality programs and that are in quality, we have to learn to be patient, right? Because a lot of this stuff is old data. Value-based purchasing, 2 years old. Health grades, 2 and 3 years old. So it takes us a while, and we have to keep diluting. So I know a lot of people get frustrated, and you got your administrators, and I'm on that side of the table as well. They're saying, fix it, fix it, fix it. And I'm like, okay, we are, but that will be in 2020. I'm just saying. So we get those kind of things. So we need to start now, because we are in that time frame where we're looking at our 2020, right? We're right in the middle of that. Outcomes. So value-based purchasing is always a big thing that we're looking at. We really need to see healthcare itself is, we've got so many financial pressures, right? We also have the finite resources, so we've got to work smarter, not harder. And I know all of us in this room work harder and try to work smarter. So there's a lot of things that we can't fix on that, but we're trying to, but we always need to start thinking ahead. So these are some of the areas that we look at. Process of care, that was more the evidence-based medicine. That was the core measures, as we call it, as well. Those are moving all to those ECQMs. So that's that shift, and I'm old enough to remember all these things going where my abstractors were worried, am I going to have a job, because everything's going to be electronic. You're not going to need me to abstract. We're always going to need humans in some capacity to go through these things, right? But we do want some of this stuff to be where you can find it and standardizing where that location is. So those of you that work with the ECQMs and know that that's going to be that electronic process, we need to be very careful and understand that getting that standardized, this is where you document every single time. And a lot of these themes, it's the same thing. Standardization is going to be key for our success. And then outcomes is also our safety areas. So all of these things, the patient experience, even that ties in, right? Because people look at you and they grade you. And if you're doing the right thing every time, you're going to do well in all of these. Your efficiency is going to time in. So we know that if we provide good care, we do good communication, everything's going to fall into place. And it truly is. It's not just words. We know that it works. So this accurate coding and documentation, these are just a few things that we look at there on that. So C. difficile or bacteremia, surgical site infections, what's that SSI is, and the mortality, AMI, heart failure, and pneumonia are the big things. But again, don't just focus on your Medicare, don't just focus on those 3. We need to look at all of them. And then our complications for our total joints, those are a big hit right now too. I think we're on a delay. Okay. All right, so we talked a little bit about this. Physician documentation, we document as clinicians in clinical terms. It doesn't make sense. Apparently back in the old days, a lot of the physicians were asked to be part of building the coding language, and they were like, no, we don't really need to do that. Kind of kicking ourselves in the butt now, because we should have had a little bit more of that say, and we wouldn't be in such a frustrating area, but then most of us wouldn't be doing this and getting gray hair either. So. There is 2 languages. There's that diagnosis term, ICD-10. I don't know if all of you have heard about ICD-11, which is the next one. But good news. I did say I was going to retire before ICD-10, and that didn't happen. But ICD-11 is actually the World Health Organization says in May that they're going to release that version. It doesn't mean that we're going to do it here. in America, yeah, because we tend to be the last. We think things through and figure out how it's going to work. But the positives on that, though, just so something looking forward to, is electronic health records. That was built to collaborate better with our EHRs. So ICD-11 is going to make a big difference for us in those areas. So it's actually something that I am looking forward to, but just not in May. All right. Okay. So we talked a little bit about this with the continuum, and I want to focus on the beginning where you get that patient encounter, and then the documentation is so key. This is where we want to do some collaboration, right? It's not just in a silo, it's not just physicians. We really need the team to help our physicians with that. Multidisciplinary rounding, interdisciplinary rounding, that's going to be key right there to support your physicians. And one of the things I like to say is if you have a clinical documentation program, and even if you don't, some of the smaller hospitals may not have that option. Maybe you can get one of your coders. I know they say that they're not very social creatures, but you do get some really good ones, and they're very knowledgeable. To be part of that, to help get that, and a lot of the times you could do your verbal queries at that time. So that documentation needs to happen all through this day, needs to be consistent, and needs to be as robust as possible. And again, CDI's in there, they're looking at things concurrently as well as they should be helping with things retrospective. The coding gets into that usually at the end before, and you want to get them involved and use your analytics tools where you can maybe put some hard stops, whether you're just looking at those certain DRGs or all your mortalities. I know a big thing, if you want to focus first, you should be focusing on your hospital-acquired conditions. So anything that shows up and it's coded out as a complication that says it was not present on admission, not POA, so that would have the N flag. Those are the ones you always want to go, stop, let's look at those and let's get more people involved. So we're going to talk a little bit about some tools on that towards the end. But if you can do that, if you can do concurrent while the patient's there, while the physician's in front of the patient, while that hospitalist is on that rotation to be able to answer those questions, that's where your biggest success is. But you also need that second layer. If you can get that stop again before coding sends it out and then all that stuff becomes public, then that's your second chance of really trying to stop that Swiss cheese model kind of lining up where all the holes, and the next thing you know, you've got this really bad reputation and you know you didn't, that you provided better care than you did. So there's things that we can do on that we're going to talk about. Compliance is a lot of the things that we also just talked about, what we need to worry about or make sure that we're doing correctly, not bleeding, risk mitigation, those kind of things. And then the quality reporting, that's the stuff that goes out. So after it's coded, you're going to go out and you're going to look at that. So that goes on our report cards, that's our value-based purchasing, that's that Vizient reports that everybody loves to look at if you're in that. But those are the things where all those codes, again, go into that quality reporting piece. And then the analytics, and a lot of people kind of poo-poo the analytics in the past, but we know the value of that now. Predictive analytics, right? Those of us that are working with readmissions, we know how valuable that is if we can do better predictions. And the only way to get valid and good analytics is to make sure that we are coding and documenting everything that's going on with that patient. So if you know how sick they are, if you know that they should have been palliative care, get those people involved early on in the stay, but at least get that documented so it's getting coded. So when you're looking at that and you're doing your analytics, you can say, this was a very, very ill patient. This heart failure, basically it's end of life. We need to make sure if they come in, either we need to, as soon as they're discharged, to make sure, what can we do to support them so they don't have to come back? Or just knowing that they're going to come back if we don't intervene. And if they do come back, it almost, we talk about that observed over expected, right? What is that possibility if we're coding correctly of the patient that actually, based on the expectation of them being readmitted or the expectation of mortality, based on what really happens. So that's when that documentation, those codes come in. So kind of like a feedback loop, and we really want to make sure that we're looking at that. And that analytics also in the documentation, if we start doing that after, so if they have follow-up appointments, we want to work with those clinics. Let's make sure we get that documentation. And I've worked in those areas too, where you have a patient that comes in for a migraine or they have strep, and that's the only thing that you would document on that record, right? those days are gone. We have got to be able to, especially physicians and hospitals, get that information. It also gives us better H&Ps if they do get admitted, so you've got a lot more knowledge in the beginning. And I've seen that difference too, where you've got the hospital saying, what's going on with these primary care physicians? You know, I've never seen such a beautiful H&P, or if you can get that interrelated information. And the same thing too, you get the if you get that great documentation and a very robust discharge summary, and that goes to that primary care physician, they are just going to love you, you know, because that really helps them understand what goes on in the hospital stay. And those are the disconnects that we've been dealing with in healthcare for decades. Okay. All right, so this is the one where we got a lot of stuff going on. We know hospital-acquired conditions. One of the things that I hear a lot of confusion about is, when is it present on admission or not? When is it going to say that we caused that issue? And that is really truly in the coding language and the nomenclature we hear, it's the considered conditions that occur after the physician writes the inpatient admission. So when that happens, they could be in the ED, right? And there's signs and symptoms. We see an infection when we're doing that look-see. And they come in and, you know, they may have a catheter, or they may just have signs of a UTI. And then they get admitted that day, and then you're trying to figure out, did the patient have that sepsis before? So you've really got to look at that whole chart. And then make sure, and that's something too, just take away too, coders don't always do a good job of looking at what happens before. So all the patients that come in, they have to focus their document or their coding on what happens during that inpatient stay, but they can absolutely look at what's going on prior to that time, and that helps us with that present on admission flagging, so we know. Again, quality it's a team sport, and we really need to focus on that. All right, so getting that present on admission, we know how much is being denied. It's actually looking at millions and billions of dollars, not so just that, but it's also things that we look at too. Those hospital-acquired conditions are areas that come out in those outcomes that make it harder for us. If you've got market shares that you're worried about, which we all do, is our inpatient volumes kind of fluctuate. If we're trying to recruit physicians to come to us, I know that's a challenge in a lot of areas. They look at those kind of things. What kind of harm do you cause your patients? Marketing, when we look at that, and you've got competing facilities, and it's not just Medicare, CMS, Blue Cross Blue Shield's heavily vested in looking at that when we're writing our contracts. So all these kind of things occur. And one of the things I think that would help, and this has happened at other organizations that we need to think about, is standardizing some of your diagnoses. So acute respiratory failure, acute respiratory insufficiency, that was a really hot topic, and it was making everybody crazy. And then we had a lot of denials based on that. So one of the things that you can do is you get your specialist, your pulmonologist, and your group of physicians together, get together with the coders and maybe a clinical documentation, and standardize what you feel in your organization based on the evidence are those signs and symptoms of sepsis. What are those signs and symptoms of respiratory failure? And then when you get those denials, you can come back and say, this is what we have. It's all clinically based. These are our signs and symptoms, and we've documented it. So you've got a little bit more of a kind of a claim, and be able to fight back to say, hey, this is it. This is acceptable. Whether you're using rifle or for sepsis, we've got the SOFA stuff that's making us crazy. Those kind of things up front. And sometimes if you get a very good comprehensive clinical indicator order set, then you can also work on getting those into your contracts, sometimes with the private payers. And if you can get those written up front, that kind of mitigates some of those denials, right? You say, hey, we kind of agreed to this last year, so we're sticking with this. And we look at those kind of things. So those are some of the things that I think would really help us. All right. Again, this is just a little bit of information for you guys, HAR and PSIs, and how clinical documentation improvement can help. Again, if you don't have a CDI program, we can make one. You can work with coders, you can work with your infection prevention staff, and your nurses. There's a lot of different ways, and we have to think outside the box. So these are just some of the PSIs under ICD-10, which will be at 11 before we know it. Coding guidance, reporting those complications of fear, your quality implications of PSIs. Again, that's value-based purchasing, your PSIs, your publicly reported data. You got your triple jeopardy things where it does readmissions, your hack penalty, and your value-based purchasing. I always say, if you got to focus on something, focus on those first. Again, we try to work smarter, not always harder, and we do have limited resources. And then come up with a review process. And again, the collaboration and the team sport. We don't want our physicians to feel like they're on a tight wire, right? None of us want to feel like that. So you really need to bring everybody in, have a strategy, put all the people at the table together, and then educate. Here's some of the PSIs. Everybody knows what PSI 90. I remember when I brought this to my board, I don't even want to say how many years ago. They're all like, what is that? And nobody's looking at PSI 90, right? And I'm like, no, I'm pretty sure PSI 90 is going to be a hot topic. And they're like, no, we don't even know. I'm not sure. This is crazy, and it's a bundle thing. But we ended up agreeing to put it on there, and now I see it all the time. And I was like, hey, I was right for once. But this is a big thing, and these are things that we look at. Now, patient safety indicators don't always indicate harm, right? So that's one thing I look at. It's really an indicator of potential harm, and a lot of these are based on that post-op, and we do want to make sure that when we look at that, that the coders understand and physicians understand, don't document and say post-op, because how we understand it's 2 different language too. It's not that period of time after for clinicians, but for a coder, that's a definite complication. So we need to be real careful with our verbiage, and again, that helps with having that collaboration and communicating. But those are things that we look at, and if we have a comprehensive picture of a very ill patient, when some of these happen, you have that observed over expected again. So you know that this patient really was set up. They had diabetes and some of these things that happen. Maybe the procedure was integral to a laceration, those kind of things. So helping with that verbiage is important. Okay, so again, we talked about a team. One thing that a lot of organizations sometimes forget is the essential of having a physician. We've got to have that physician advisor, that physician champion, physician leaders involved. To be successful. But in order to do that and get their engagement, you have to be very careful to make sure it's a good use of their time. We have to be efficient. When we're looking at that and educating, I love to bring an actual record of one of their patients with me to look at that and do a chart review so they can understand, and then show them with those trigger words what they mean in coding language versus clinical language, and that brings it home a little bit more. But again, if you've got clinical documentation nurses, they need to be rounding, they need to be in front of the physicians, they don't need to be behind a computer, and they've got to be on so many of these teams. Your nursing supervisors, your nursing staff. I've had nurses on the floor where I said, if Dr. Jones comes up there, he's got like 15 queries that need to be answered. We need to get this done. Administrations like our DNFB is huge. But we also want to make sure that we get them to understand what we need from them, and then answer their questions. So they'll call us and say, hey, he's up here, we're going to delay him, get up here real quick. So get them on there and let them know about this stuff. I've got a new PI specialist that she just gave me. She's a nurse on the floor, and she's a nurse manager. And she said she did not know what a lot of the VBP was, the value-based purchasing, and just got into it. She's like, oh my gosh, you need to know about this stuff. Everybody needs to, and they'll understand a little bit better. So, if you're hearing that from people and they understand, and I'm one of those people that if I understand, I do better. Coders, again, try to get them out of that basement, because they have a lot of valuable information. You're a PI specialist, and that's a lot of us in this room. A lot of times they forget, and we are in up to our eyeballs in these value-based purchasing and all these other things. So patient safety and quality leaders, again, the people that you need, your respiratory, wound care, bring them in for pressure ulcers, right? They can help, and knowing the physicians don't have to stage, sometimes that helps them, right? They're like, oh my gosh, help me out here. And that's one of those coding things that you don't have to worry so much about. This is just something for you guys to look at. There's different ways to do this. When I call it a hack attack, this is real time versus stopping at before it gets final build. So there's different ways to do that on a process map that you can go through that. Coding accuracy, again, present on emission status, you've got to review for that stuff. Look at that previous information. Get your IP directors involved, or your IP nurses. They can help look for those, and a lot of times they already know about them. Have them communicate. Say, hey, I think we've got a case of sepsis, or I think we've got a cabbage or a CAUTI, and talk to each other and keep an eye on that. Again, we talked about avoiding some of this language, post-op and post-surgical. Telling them incidental, we talked about that a little bit. Help them with that verbiage so they know how to say that. And then make sure you've got a good coding policy that talks about what you need to have in there so they know. Here's just another tool that you can look at for post-ops. We want to put them in those buckets so we can learn. Again, we want to be efficient, so if we use these and say, oh, we've got documentation issues, we had a coding issue, you've got them in those buckets and you've got information to talk to. Sepsis, a lot of people have been talking about that, under-reporting and over-coding. Again, clinical indicators, if you've got the documentation, that's not a good, that's what's going to get you through that. So if you have questions on that, we're going to be available for questions later on that, but there is a lot of concern right now with the sepsis about either undercoding or overcoding. And one big takeaway, physicians remember, and those of you supporting them, if they could just say, what is this due to or manifested by, that almost always answers what that diagnosis should be, okay? And then linking them, which is essential these days. How to do buy-in. Get your physicians to speak to this. Find those people and have them present, not just us speaking to them. But you really need to go through and you need to communicate. We do not communicate enough to our physicians or even others. Go to your nursing department meetings. But if you can talk to them and tell them what's in it for them and how it affects them, whether it's their profiles or their reputation, they understand it. And then you say, we're here to help you. So it's not just giving them the bad news and makes me want to curl up and ball and hide in a corner sometimes. You're telling them what you're going to do to support them. So know your opportunities, focus on those high impact areas, create those reports, track and trend, and get that physician champion. Again, a lot of us don't have the money to hire somebody to do that, but you can get somebody to buy in and then have those one-on-one conversations. And a lot of times we've got to get up more than one. Use those tools, what we talked about, setting up that alert, so before it goes out the door, we get a chance to look at that one more time to see if we agree. Have regular meetings, and again, they can be just quick daily huddles, which is 5 minutes, but if you don't have an infection that you're looking at, you don't have to have the call. But valuable use of people's time, not another meeting just to talk about it. And just make sure really that we celebrate our successes, because this is a lot of hard work. We said it takes a lot of time to get through it. Couple years to get some of that stuff cleaned up and diluted every year, but make sure you do that and say thank you. Thank you to our wound care nurses, thank you to our physicians, thank you to the coders. And then you can focus, once you get that documentation issue taken care of and you're coding accurately, then you can really focus on true harm at the same time, and all the efforts focused on true harm, not just these little things that the verbiage is kind of throwing us off and giving us a perception of something else. And that's really what we want to get to. So here's just a recap of the things that we need to do. Again, our ultimate goal too is we want to decrease the number of queries, and that would make Dr. Bowen and others like her very happy because it keeps us a lot safer. And physicians too. Nobody likes to know you've got 552 queries you need to answer before you can take your vacation. All right, so we are going to be outside, but do we have any time? And I know I'm a talker too.
Okay.
Before we do that, I wanted to I think we have some time for questions, but before we do, Dr. Smith, I think, had a couple of comments relative to the QIO role.
Just real quickly, thank y'all very much. That's I'm still scared after we don't want you guys to be scared.
We're here for you.
All right, and that's what I want to say. And so Kathleen mentioned the QIOs, but let me just make clear to you as we can that She's not talking about us, okay? So the CMS changed the QI world about 5 years ago, and there are BFCC QIOs that do the review work. And that group for everybody in this room is KeyPro, a group that's north of Huntsville. They're not in the state. And as most of you know, the administrative contractor has changed recently, and they're in South Carolina. And there are ZPIC coordinators and all kind of other RAC and other contractors that do all of this work. So I just wanted to share with you, it's not us, it's not what we do. When the phone rings and you see the speed dial says AQUAF, we're not there to look at your records. We have no regulatory authority, all right? So we're here for you. And so we'll be glad to help your team. If your team is assembled, and we can pull your data, and we can look at your processes with you and help you in any way that we can. So again, a lot of different QIOs out there, but just wanted to make that brief editorial comment. Thank you.
All right, good. That's a great disclaimer. Is that
Thank
terrific?
you, Fred. I appreciate it.
Yeah. All right, well, we have a few minutes for questions. If anyone would like to address any, or I will pause a moment. Rosemary has a microphone. I was looking, Margaret does have one, okay. Dr. Smith has the microphone. Any questions for Dr. Bowen or Jennifer? One right down here.
Oh, no.
So just a question out of curiosity, I know that there are organizations that review practices and CMS charges for deliberate fraud, like the plain pill clinic places. So do those groups do the kind of auditing you refer to and find the hospitals, or are there two different groups? I'm just, you understand what I'm asking?
Yes, I do. So,
Well, let me rephrase, because the groups that look for deliberate fraud don't do any charges or don't file any charges until there's $12 million have been accumulated in fraud. So I think the hospital you referred to was less than that. So, you know, there's the hospitals that don't do the right coding, and then there's the groups that purposely do that, and we've seen lots of that. So there are two different groups that audit and fine.
So there are many different groups that audit, but most of the audits come, that we assist with come through falling off the bell curve. So there's a standard, all of the agencies have a standard, and they have a work list. And they go through their work list and whatever the hot topic is. Like I know right now, sepsis and malnutrition, those are hot topics. And so for overcoding. So that if you submit claims, an inordinate number of claims that have those diagnoses, you will then be referred to an agency to be audited. And so for the most part, how fraud is caught is because their billing patterns exceed the norm of the bell curve.
Which is important for you to look at your PEPA reports too, just saying.
It's good, you need to know where you are. Yep.
I certainly don't want this to be an area of expertise, but I think in adding to that answer, due to the multiple agencies and the multiple components that are out there, I don't think there's a dollar threshold that would protect you or allow you. It could be as simple as a whistleblower from within an organization or a vendor relationship. It could be any of the agencies that have the oversight for both the collection of analytics and the data. It could come from another payer source outside of CMS. It could come from a variety of locations, but I wouldn't mentally think that there's a dollar threshold that you can stay along. What they're looking for is either a pattern or a trend or a deliberate act, and really any of those can kind of get you into hot water. Many times there are reviews that don't lead to anything. Again, you will see sometimes other agencies outside of CMS. You'll see the FBI, you'll see the Department of Justice, you'll see some other parties that can get involved. And so I think the biggest message I get in all of this was, you know, we do our best to do it right, and making sure we know the rules as best we can, and keeping ourselves up there is probably the best protection as an industry we can have. And if we find that we have something that's going wrong, obviously we all have compliance programs. We have all opportunities to step forward and say, this is an issue that needs to be addressed, and generally they look very favorably at that. But it's treacherous waters out there for sure, but I think as long as we have a good moral compass with what we're doing, generally we're going to be not have problems. Any other questions from the group? Okay, well, Jennifer, Dr. Bowen, we thank y'all very much. Very well done. Let's give them a round of applause. I will say that this conversation that we're having this morning actually came out of one of our monthly quality task force meetings where we'd invited Jennifer to come at the request of some of our members in that group. So I would again say to those of you who do not routinely participate in that monthly meeting, there is an open invitation for quality leaders in our state. You can go through Rosemary and Margaret to get that information. We convene monthly about 10 times a year. We take typically a couple of months a year off due to holidays, etc. But again, some of the best work comes out of the networking relationship that exists there. And we have on any given month probably 50 to 60 of our hospitals in the state connected to those topics. So this is one of those that came out of that. And I think it turned out to be a very good topic at our breakfast session and also a topic this morning. So thank y'all very much.